Hello, my name is Emma Holliday, and I am an associate professor of gastrointestinal radiation oncology, and I treat patients who have anal cancer. What I have been asked to do today by the Anal Cancer Foundation is to deliver a talk entitled Anal Cancer 101. What I hope to accomplish in our brief 10 minutes together is to cover the following. What is anal cancer? How do we treat it? Why do we treat it that way? And finally, where are we going from here? What's coming down the pipeline? What is new and innovative and personalized in the treatment of patients with anal cancer? So, starting with the basics, anal cancer is a rare malignancy that starts in the lining of the anal canal or in the skin that surrounds the anus itself. It's rare. It only makes up for about 10,000 new diagnoses per year here in the United States. And for the purposes of our time together, when I say anal cancer, I'm specifically talking about anal squamous cell carcinoma, which is far and away the most common type of cancer that arises in the anal canal and the perianal skin. When I meet a patient in clinic, almost always one of the first questions they ask me is, why? Why did this happen to me? Why did I get this cancer? And the most common risk factor or the most common reason that someone will develop anal squamous cell carcinoma is infection with the human papillomavirus or HPV. It is a charged conversation because I do think there's still some stigma surrounding HPV infection, but there shouldn't be. Those of us who are not young enough to have received the HPV vaccine in our adolescence, the vast majority of us have encountered this virus in our lifetime. And most of us are just lucky enough that our body cleared the virus and we didn't have any lasting ill effects from our infection. There is just an unlucky few, an unlucky minority, where HPV causes some changes within the cells in the anal canal or the perianal skin. And these cellular changes, these molecular changes, allow a cancer to develop over years. HPV is the most common, the most important risk factor, but it's not the only one. Other risk factors for anal cancer are smoking, a weakened immune system, like my patients who have a kidney transplant, for example, and have to take immunosuppressive medication. Having an anal fistula or some other type of chronic or ongoing anal irritation is also a risk factor for anal cancer. And then you also see age listed as a risk factor. Because anal cancer typically develops slowly over time as a result of these cellular changes that can occur, the most common time period or the most common decade of one's life to develop anal cancer is in the late 50s to mid 60s. Next, how do we stage anal cancer? So, anal cancer is staged based on how big the tumor is, whether or not it invades other organs in the pelvis, like the bladder or the vagina or the prostate, whether it spreads to lymph nodes in the pelvis or the groin, and then finally, whether or not it is spread to other parts of the body or metastasized to places like the liver or the lungs. When we talk about stage 1 anal cancer, we're specifically talking about the smallest anal cancers, less than 2 centimeters, that haven't spread anywhere. When we talk about stage 2 anal cancer, we're talking either about the smallest tumors that have spread to some nearby lymph nodes or medium-sized tumors, less than 5 centimeters, that have or have not spread to nearby lymph nodes. When we make the jump to stage 3 anal cancer, that's defined by a tumor that is either large, bigger than 5 centimeters, a tumor that invades other organs within the pelvis, or some combination of the two. What defines stage 4 anal cancer is that the cancer has spread outside of the pelvis. It's metastasized to a distant organ, something like the lungs, the liver, or lymph nodes outside of the pelvis. Okay, so how do we treat anal cancer? We treat anal cancer with radiation and chemotherapy for the vast majority of patients. If you have stage 1, 2, or 3 anal cancer, typically the treatment is going to be chemoradiation. There are a minority of folks who have really small stage 1 tumors that can be completely removed with a minor surgery. So for them, that would be a treatment option. Surgery is also reserved for cases where chemo and radiation doesn't work. If the tumor doesn't respond fully or go away after radiation and chemotherapy, surgery can be used as a salvage. When we say chemoradiation, the schedule for this is typically between 5 and 6 weeks of radiation therapy, where radiation is given Monday through Friday. And chemotherapy is given usually as a 2-drug cocktail during that same 5 or 6 weeks where the radiation is being delivered. So, I wanted to touch on a brief history of why we treat anal cancer the way we do, because in the 1970s and before, anal cancer was actually treated with surgery. The surgical treatment of anal cancer was a big operation called an abdominoperineal resection, where the anus, the rectum, all the lymph nodes were all removed with the big operation, and patients were left with a permanent colostomy bag. This is a tough treatment and it impacts quality of life, but also in the 1970s, it wasn't very effective. It only resulted in cure about half of the time. So it was actually a surgeon that had the idea to try radiation and chemotherapy for anal cancer. Dr. Nigro, you see him here, had the idea to give 3 weeks of radiation with mitomycin C and 5-FU, and he intended to give this as a preoperative treatment. And what he hoped was the tumor would shrink a little bit, and the preoperative chemoradiation would reduce the chances that the tumor would come back after surgery. But what he found was that it worked so well, it actually put him and other surgeons out of a job for a lot of folks. Because even in his early studies in the 1980s, he found that about 75% of folks didn't need the operation because the radiation and chemotherapy took care of the cancer completely. So, since the 1980s, from the 1980s to about the 2000s, researchers and doctors set about trying to refine or improve on Dr. Nigro's original protocol. So, there were some studies done that looked at maybe doing radiation by itself. Maybe we could drop the chemo. Turns out we need them both. That's what the studies in the early 1990s showed us. In the late 1990s, there were some studies that looked at maybe switching out some of the chemotherapies, maybe swapping the mitomycin C that was used classically with a drug called cisplatin. The studies there were a little bit mixed. One of the studies showed patients who got cisplatin did worse, and another larger study showed that cure rates were the same, but toxicities or side effect profile might be a little better with cisplatin. Even so, as a result of those two studies, mitomycin C and 5-FU remain the current backbone of the standard of care treatment today. From my standpoint, as a radiation oncologist, the big shift came in the early 2000s when we developed a more modern technique, a more precise technique of delivering the radiation therapy. Prior to the early 2000s, we treated anal cancer by aiming a big radiation beam at the pelvis. We treated the anal cancer, but we also hit every organ on the way in and on the way out. And so the side effects of treatment were significant. And when we switched to this newer technique, this more precise or conformal technique called intensity modulated radiation therapy, while I'll admit side effects are still a lot higher than we want them to be, they are a lot better than they were in the 1980s and the 1990s. So, where are we going from here? There are two open questions or open lines of research in the anal cancer community. The first is we know that a one size fits all approach to anal cancer is not what we should be doing. We know there's a group of patients with very early stage tumors, stage 1, early stage 2, where the status quo the 5 to 6 weeks of chemoradiation is probably too much. We probably could cure folks with early stage disease with less radiation, and that would lead to fewer side effects and better quality of life in life after cancer. So, that is one line of research, line of inquiry. On the complete other end of the spectrum, we know that there are folks with big, bulky stage 3 tumors where the cure rates aren't anywhere near where we would like them to be. And rather than dialing down the intensity of treatment, there are some folks where we want to turn the dial up. And so there is a separate line of research, of study that aims at trying to intensify treatment for folks who are at highest risk. In terms of the folks with earlier stage disease, where the status quo may be too much, there are a couple trials recently completed that ask this question. Plato Act 4 was done in the United Kingdom, and the ECOG Akron decrease study was performed here in the US. Both of these studies looked at turning down the dial of radiation, giving less radiation to see if we can maintain excellent cure rates while reducing side effects and improving quality of life after cancer. And we have some promising early results. The 6 month data from Act 4 were published just this summer and showed that when we dialed down the dose of radiation from 50.4 to 41.4, we saw that at 6 months, the complete response rates, or the percentage of folks for whom the tumor was gone, was about the same. It ranged somewhere between 87 to 92%. And that was coupled with what you would expect, reduced toxicity and better quality of life in patients who got less radiation. The ECOG decrease study, we're still waiting on results from this trial, but hopefully if the ECOG decrease study shows similar results to Act 4, we may be able to start turning down that dial for patients who have the earliest stage disease. On the other end of the spectrum, the patients for whom the status quo might not be enough, there are some ongoing studies and ongoing lines of research looking at how to escalate treatment and do better for those folks. Again, in the UK, Plato Act 5 is looking at turning the radiation dose dial up a bit for patients with larger tumors or involved lymph nodes. There was a study also done by ECOG Akron that closed a couple years ago that looked at adding immunotherapy after the completion of chemo and radiation. And then there is an emerging line of study aimed at kind of personalizing treatment escalation or intensification by looking at circulating tumor DNA blood tests. So in the future, we may be able, after someone finishes chemo and radiation, draw these circulating tumor DNA blood tests and personalize how much additional therapy someone may or may not need. It also it may allow us to catch recurrences earlier than we currently do and treat them more effectively and hopefully with fewer side effects. So no results to share from any of these studies as of yet, but these are the ongoing and up-and-coming questions in the realm of treatment escalation. So as I conclude my time with y'all, my take-home messages are this. Anal cancer is a rare malignancy. Yes, we do treat it currently with a very similar treatment paradigm to what was developed in the 1980s, but there have been incremental refinements along the way. And most excitingly, the future directions of anal cancer treatment will be personalized. We will look at dialing down treatment for folks who are at particularly low risk of cancer recurrence and high risk of cure. And we will look for new and novel and exciting ways to turn up the dial and escalate treatment for folks who are at higher risk of the current treatments not working. And hopefully this will allow us as doctors, as anal cancer researchers, to help find that holy grail, that best, most optimal balance between cure, and also quality of life in the life after cancer. So, with that, I want to thank you. Thank you for your time. Thank you to the Anal Cancer Foundation for this invitation, to my colleagues who are doing this hard work, researching better treatment options, and finally to my patients and their families and loved ones. You have been my most important teachers on the importance of doing better for patients with this disease. Thank you.